Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to another episode. Today, I'm thrilled to have Priya Jayadev from Volunteer Hospice of Clallam County with us. Hospice care is such a crucial support for those at the end of life, but unfortunately, not everyone has equal access to it. Whether it's due to financial struggles, cultural differences, or just not having enough providers in the area, many people are left without the care they need. In this episode, we'll be talking about these barriers and explore the amazing work that Volunteer Hospice of Clallam County is doing to make hospice care accessible for everyone. Priya, welcome, and thank you so much for being here today.
Thank you for having me, Traci. It's a pleasure.
Can we start off and have you tell us about your journey to VHOCC?
Yeah, absolutely. So my journey's a little different than the usual. My training in background is in cell biology and biochemistry, and I came to the Olympic Peninsula having left the science arena to move here to focus on family. I initially started out with nonprofits, working for an organization that served people with intellectual and developmental disabilities. But when the opportunity came at Volunteer Hospice, what I realized is that it was the perfect opportunity to marry my two different career routes, one being science and the other being nonprofit. So I joined Volunteer Hospice in September of 2022 in order to kind of bring back that science medical focus to my career. Yeah.
And can you share an overview of Volunteer Hospice of Clallam County and what your mission means to you and the community?
Yeah, absolutely. So, Volunteer Hospice was founded in 1978 by a force of personality named Rose Crumb. She was a nurse who had had the experience of doing hospice-like care for her father at his end-of-life journey, much before the whole hospice era kind of came to the US. And if you'll recall, in 1974, hospice was first introduced at Yale New Haven Hospital. Clallam County, Washington, one of the tiniest counties in Washington state, had our first hospice in 1978 because Rose Crumb had a vision and she made that happen here. So it was way before Medicare came into the game, way before most people were practicing the concept of hospice. It was an amazing thing. And in fact, many people told Rose, hey, why do we need that here? We don't need that here. And she was like, no, we're going to make it happen. And she did. And what she created was an organization that is very much patient, family focused, community focused, supporting people in that death and dying journey, because she knew there was a need to make things different than what it was at the time. And so when Medicare came into the game in the 1980s, I think it was 1985 that the Medicare benefit passed, Rose was adamant that we would remain an independent hospice. And she mobilized her son, Patrick Crumb, who is an attorney, and she mobilized Derek Kilmer, who was a legislator in the state legislature at the time. And he's currently in the federal legislature for Washington State. But the two of them put Rose in front of the Washington State legislature over and over and over and over until she got what she wanted, which was an RCW legislative exemption, a law stating that we could operate independently and continue as we have. And that really changed the game for us. We were able to operate as an independent hospice. And if you think about it, there may be 6 of us in the nation that operate as we do. We have a professional staff of nurses and aides and mission support individuals. But we don't bill Medicare, we don't bill Medicaid, we don't bill insurance, we don't bill anyone, not the patient, not the family, no one. And that's a very unique model because we still have paid staff doing clinical care, but we're not asking for money except as donations and grants and support. It's a different way of operating, which allows us some freedoms. It allows us to bring on patients who may not have a 6-month trajectory to end of life. It allows us to bring on patients who are still a little bit cautious about giving up curative therapy. It allows us to bring on patients who would like to continue dialysis or other things that are not part of their primary diagnosis that allow them to go into hospice care. But it allows us to provide the best comfort possible to the patient and the best emotional, spiritual, and caring support to families as well. That said, we are very different in that we only have nurses and aides, as opposed to the standard Medicare hospice has an interdisciplinary team, which includes medical providers, which includes social workers. Much of that we rely on the existing care team that the patient comes in with, or volunteers. So every patient that comes onto our caseload is able to keep their primary care provider, is able to keep their cancer care provider, is able to keep all of the other people that already exist in their medical care team. And we come alongside for the hospice palliative piece. And then we support some of the emotional, spiritual support through our cohort of volunteers. And in fact, if you look at our team, we have about 21 staff, paid staff, and we have about 200 volunteers. And if you look at that from an FTE perspective, it's about 13 full-time staff, 7 full-time volunteers. It's essentially that breakdown. It's an amazing thing, because what it means is that when our nurses need to go in and spend 5-6 hours with a patient, they're able to do that. They can spend 5-6 hours with a patient when necessary. They're not counting, I have to make 5 visits today. If it's necessary to move a couple of visits to another day because there is a family in emergent crisis, that is what needs to be addressed. So it is very family and patient focused. It's a unique way to operate, and I think that's what draws most of our nurses here. They come here because of the heart they have for hospice, but also the ability to do nursing care, hospice care as it was originally meant. And it's an incredible thing to be a part of.
Yeah, that's very different from what you get in, regular hospice. I would say, not that you're not regular hospice, but where you have 45 minutes once a week. And I know that a lot of nurses get burnt out, and I'm seeing a lot of hospice nurses actually moving on to being end-of-life doulas, because they're like, this is what I really got into the field to do, to really be present with people who need that. So it's really interesting, and I know that the nurses that they do want to spend more time, that the entire care team, it's just that their hands are tied at this point. And I know the community, does a person need to live in Clallam County to get services?
For us, yes. Our service area is very distinctive. If you know the geography here, it's from Diamond Point to Joyce. So we don't even cover the full extent of Clallam County, simply because the geography of our county is rather extensive and it's hard. I mean, we do everything for free. And so adding a patient doesn't mean adding dollars, it's actually adding costs. So we have to be conscious of that, and we strive to do the best that we can for the patients on our caseload. So we have an area that we span, and that is who we serve. But that's in the hospice and palliative care. We have some other services that are available more with a larger geography, let's say. Do you want me to speak a little?
Yeah, I do. I'm curious. And then we'll get back to the hospice, but I'm curious about what else you do.
Yeah, so we have a lending closet, which has an extensive amount of durable medical equipment, incontinence supplies. Anyone who can stop in at our office is able to borrow something. So sometimes we've had people who borrowed a walker for a sibling who lives in Seattle, for instance. That's fine. If you could stop by here and borrow the equipment yourself, you can definitely do that. And it's free of charge and for as long as you want. And it's been years for some people. Hospital beds are delivered. So they're only to people in our area, in our service area. Walkers, wheelchairs, crutches, boots, all kinds of things are also available and available to anyone. We also have a grief and bereavement program, which is available to anyone in Clallam County throughout the county. You just need to call. There's one-on-one, and there's as well group-based support. Group-based support requires you to be present. And then we have a soul care program, which is an informational seminar series, which is via Zoom. Our speakers from all over are from all over the world, and our attendees are also from all over. So yeah, there are some programs that are accessible beyond our area, but the main core of hospice palliative care is for our area for sure.
Yeah, I love that you focus on grief after. A lot of programs, a lot of hospices do, but they don't necessarily do it to the extent that people need it. There are, like, Medicare says that the minimum you do is 5 or 6. I think it's 5 sessions over a year. That's minimum to meet Medicare standards. And so a lot of hospices, I think, just do that. And that's unfortunate because, yeah, people need more than 5 sessions. And we know that grief is much more than just a year. In fact, the second year is usually harder than the first year, actually. But I love that you do that. And I love that you have educational series also. That's so important.
Oh, sorry, go ahead.
I was wondering, how do the physicians and the medical teams that you work with, how have they teamed with you? How does that work? And have you had a lot of support?
Yes, and there have been challenges as well. So yes, I think once the physicians and providers understand who we are and what we do, and that we are a real hospice, right? Just because we don't bill doesn't mean we're not real, right? As soon as they understand it and they understand what we're doing is pretty much standard of care, right? They're on board. And in fact, they support us to the point of they prefer us in many cases once they understand us. The challenge comes from when a referral comes out of area. So we often have patients who are referred from Seattle and Bremerton and Bainbridge, which is outside our service area. And those physicians really have no understanding of the fact that there can be a hospice that operates as we do. We don't exist in the arena of Medicare hospice, and we don't exist in their evaluation system as well. So it's hard to find us if you don't know about us. And once you know about us, if you're from out of area, the understanding that the provider needs to continue to be the provider and that we are not coming in to take over, but we're coming in alongside, that's an educational piece that we need to constantly do with providers. And that challenge exists with providers from out of area and also traveling providers that are here for periods of time. And as you know, with the pandemic, there are more and more and more, especially in rural areas, travelers who come to rural areas to provide service because we can't get the workforce we need here. And so we're constantly in this mode of reaching out to partners and educating in order for them to understand how we practice, how they can partner with us, and how we can provide that best care for the patient and family. Yeah.
Now I'm going to ask a question that I'm probably not supposed to ask, but I want people to get an idea of what you're working with. As far as budget, what is your budget? Because I know it varies from year to year depending on your donations. I want people to understand how little you actually work with.
Well, actually, our budget is pretty extensive. We have a $1.8 million budget because staffing, and staffing represents about 85 to 90% of that, right? Staffing to have good nurses who can go into the home, staffing to have good aides to go into the home. That is the key priority for us. Our wages are probably within 80% of market levels, but they're not at 100% of market levels. But nonetheless, with a staff of 21, it takes a $1.8 million budget to make that happen with clinical wages currently. Yeah.
I know you say that's extensive, but maybe it's because I live in the Bay Area, but for for a hospice budget, that is not very much. So that's,
And that's partly because, I mean, if we need a social worker right now, we're about to hire a part-time social worker, but we also have an extensive volunteer group with social work background who are retirees. For spiritual support, we have chaplains who are volunteers. I mean, we rely on our volunteers. Our whole front desk, our administrative stuff is run by volunteers. Our lending closet run by volunteers. Our deliveries, all volunteers. It's possible because of that.
So I'm going to switch a little. I want to talk about the phobia of death and the resistance to accessing hospice care. And I know I see it all the time in what I do, that a lot of people come to hospice in the last weeks, sometimes days of their journey. I mean, I think that Jimmy Carter has done a wonderful job in promoting hospice. Amazing. He's just amazing. I mean, right until the end, he is doing what he does. He's amazing. So why do you think patients resist going on hospice or seek it, too late in their journey?
So I think there's a lot of factors. Death is still one of those taboo subjects. So many subjects have stopped being taboo, but death, man, is it still a taboo subject, right? Some don't want to acknowledge their own mortality. I mean, there's that piece, right? And then some think that talking about death is actually going to expedite the process. So those are all things that culturally underlie our whole concept of death and dying. Even saying the word death and dying, many people are like, oh, my loved one passed. They don't say they died, right? There's a hesitancy to talk about death and dying. It's an uncomfortable, difficult topic, and it brings about feelings like sadness and regret and oftentimes depression, and those things start bubbling up and people are resistant to move forward. But and that piece carries over to hospice. Many people feel like if I talk about hospice, if I go on hospice, I'm going to speed up my dying. I'm going to die faster. But in fact, if you look at the data out there, there's a suggestion that going on hospice actually extends your lifespan beyond what people would have expected, because that comfort, that emotional stress relief actually leads to a better dying process. And actually, with that relief, people are just more calm and actually live longer. So all that said, it's I think a bit of that feeling of we want to live forever. We want heroic measures. And when are we willing to give up those heroic measures and admit that, yes, we're mortal, we're all going to die. And I have a life-limiting illness. How do I live with that in the best way possible so that my end of life is the best that it can be, as opposed to filled with painful treatments, painful, processes, and painful invasive surgeries that really maybe won't do all that much for extending my life. And I think changing the narrative that way might help. There's also the piece that in the olden days, we used to live in these small communities. Everyone saw death around them, right? I mean, the child wasn't protected and put in a different room from grandmother who had died and was lying there in the bed just having died, right? The child would run in and see, oh, grandmother died, right? But now it's protect the child, protect people from the death piece. And I think we need to go back to that traditional piece of death is a part of the normal life process, and we need to recognize it and realize it. And as you said, with Jimmy Carter going on hospice, hopefully that will help us as well in terms of accepting that death and dying is part of this, and hospice isn't actually shortening his life.
Do you think that there's other things that we can be doing as in our communities to help with that, to help with those fears about using hospice?
Yeah, so there's been this movement for death cafes, and we actually host one called A Tea to Die For. So having forums where people can come together to talk about death and dying is a key piece. We sometimes we have some card games that we've bought, the Hello game, the Death Deck. There are other card games like that, but they allow you to make it almost gamify the conversation. Not that the conversation about death should be a game, but it allows you to have in-depth conversations, but start from a very unthreatening way. I think there are forums where there are websites like the Conversation Project and other ones, and I can get you a list of some of those, but that allow you to go and find out ways to start broaching the conversation. Some of it is that people need to start broaching the conversation, right? People need to seek out where are their forums to go and have discussions outside their family, but also start having those conversations inside the family, including the advanced planning discussions. And there are formats like the 5 Wishes framework, which allow you to go through a series of questions that you can answer and you can use as a mechanism to really spur conversation and express, what do you want your death to look like? What are your goals? What do you want for comfort? What do you want for extensive measures of care? Those kind of conversations, once they're had, people actually feel relief. But starting it is hard. So having these conversation starters, whether through game cards, whether through attending a death cafe, whether through attending a death dinner, whether through any other of these formats, starting through something that gets you an easy entry point will help.
Yeah, and some of those card games, the Death Deck, I'm sure you're familiar with it. And they have the End of Life deck also, but I really, those are fun. That's really, really fun. And I agree with you. It's a conversation. You could fill out the paperwork, but that doesn't mean anything unless you have those conversations. And those are tough conversations. But your family, your loved ones, your significant other, they should know what you want. And that comes down to your values. That's really your value set, and hopefully the people around you have similar value sets, but they need to understand that, because there are decisions that will need to be made that aren't, in those 2 sheets of paper.
Yep, exactly. And also that conversation of who represents you when you can't represent yourself. I mean, so important to think it through, because child A and child B may be very different in their framework of what is necessary in healthcare, and picking the child that more aligns with you, or it doesn't have to be a child, but whoever it is that represents you, make sure that voice is yours, right?
Yeah.
That's critical.
Yeah, and you just never know. My oldest brother and I have different viewpoints about certain things like feeding tubes and, that. And it came out in conversation when we were talking to our parents, and it was really interesting because I had no idea. This isn't stuff that my brothers have talked about. We've had conversations about, but just having that one conversation was like, oh, okay.
It's very different.
Yeah, it is. It's
Yeah.
The Medicare hospice benefit is almost 40 years old. What policy changes or advocacy efforts do you believe are necessary to improve hospice care across the U.S.?
So if you think about 40 years ago when the Medicare benefit came into play, the benefit was designed for that short, steep end-stage cancer patient. That's not the patient of today. That's not the major patient in hospice today, right? It's a wider range of conditions that are covered. And in fact, I just need to look at some statistics, but the Medicare data book came out in July 2020, July this year. And it says that in hospice care, 25% of hospice cases had a primary diagnosis of nervous system disorders now. Only 23% were cancer, and 22% are circulatory diseases. The trajectories of those diseases and how those diseases experience end of life, very different. The Medicare hospice was designed for that end-stage cancer patient. Very different now. in terms of who hospice is serving, right? Which diseases it's serving. And cancer treatments have come a long way in 40 years. So the cancer trajectory is very different. So there's a couple of things that people are talking about. Is that 6 month to dying really an appropriate time length is in question? Because if you take a look at neurological diseases, they oftentimes stay on hospice for 159 days, as opposed to cancer patients staying on for, I don't know, 52 days? So it's a very different trajectory, and what the needs are of the patient are very different. So I think there needs to be more discussion about that 6 month time frame for hospice qualification. Also, the pay structure in Medicare, I think, has had minimal changes year on year. And while it is something that has proven to be lucrative for some organizations, I think it's still difficult for the nonprofits in the hospice space to operate and do okay as a business. As you say, it's not easy to operate a hospice with a full medical team of provider and nurses aides and social worker. It's an expensive business, and I don't think the hospice benefit has kept up with that. So you almost have to do things very efficient and very much in a business-like format to make it work from a business standpoint. So that needs looking at. Also, as the benefit is laid out right now, there has been some bad actors in the area. And so I think there needs to be more oversight built in and differences in oversight. And there's actually a bill that was introduced by a representative from Oregon last session to overhaul the hospice care benefit. And it could bring all about a number of changes. Some of the things I mentioned may be in discussion through that. I think it's called the Hospice Care Act. The conversation is happening now. I think there will be changes to hospice care in the next decade. What that will look like, I can't say, but I think those are some of the points that will be discussed.
You mentioned that nonprofits and hospice care, they're very minimal, small amount. There's 22% of hospices in the U.S. are nonprofit, 3% government run, and then a whopping 75% are for-profit hospices. Do you think that there are disparities in care depending on the care provider type?
I do. I know that for us, there's disparity, right? I mean, we're different. We can do the long visit. We can focus on, the key needs. We can do a treatment for UTI, those kind of things. I don't know about all the other hospices, but I suspect that they have more freedom to spend more time with families. I'm suspecting they're not counting how many visits as much as a for-profit large hospice. A hospice that belongs to a conglomerate of 1,000 in the nation versus one that focuses on the community, there's going to be more of a community focus. And that community focus in and of itself, I think, brings more heart to the work. And I think that will manifest as better care for the patient.
Yeah. It's looking at the values of the community versus values of the entire country or a corporation, most likely the values of the corporation, and being really able to pinpoint what that community needs there's such an advantage to that.
And actually, so, there's about 18% of hospices in rural America. Mm-hmm. And one of the barriers to accessing hospice is that cultural awareness of end-of-life practices. A nonprofit hospice is going to be much more attuned to the cultural waves of the community that they are in than a for-profit that has numerous hospices all around the country, right? That nonprofit that focuses on that community is going to know their their community better so they can address some of the cultural barriers to access. They can actually host death cafes and such that are much more in line with the community that they serve than one that's in an urban community, right? Those kind of things I think matter.
I know before you mentioned some of the bad players in hospice. There's been, we see the headlines about negligent and fraudulent actors in this space. What should people look for? What should they be concerned about?
Yeah, so I think a lot of this started because there was a New Yorker article in the end of 2022 called Endgame, which really brought some things to light. I will say the bad actors are few and far between. They are not the majority, right? Even in the for-profit, nonprofit, government space, it doesn't matter which space. The fraudulent shysters are really the minority, not the majority. So that's number one. So generally, people should not be worried that hospices that they are working with are going to be those folks. That said, there are resources out there as patients and families look into hospices. There's a state hospice and palliative care organization for most states. And those organizations usually have a website that offer a lot of resources, information about what questions do you ask when you're looking at hospices. Let's say you're living in a community where there's more than one hospice available. Each person should go and evaluate every single option, right? But when you go to evaluate those, what questions do you ask? How do you know, right? So the state organizations in hospice and palliative care will oftentimes provide a list of questions to ask a hospice provider. And they will also give you some understanding of where you can go and look at quality measures that Medicare mandates are reported up. Who does report? Who doesn't report? How do they rank? Those kind of things are available for people to look up. And then families and patients, ask questions. Ask, who is your provider? What is your policy on X? How do you feel about Y? How much time do you spend with a patient? How many visits do you generally have? As I'm getting closer to being terminal, what changes in practice do you have? All of those, it's on the patient and family to ask those questions so that they get the care that they want. They find the care provider that they want. It's just like any other medical practice, right? You're going to find your best PCP. You're going to find your best cancer care provider. Ask questions just like you would when you're trying to find your PCP or any other medical provider.
Yeah, and do way beforehand, because it is, I'm not going to say way beforehand, but beforehand. Okay. Because in the moment, you're going to feel very stuck with whoever your primary or the hospital says, go to this place. And you just don't want to be in that situation. And know that if you are using a hospice and you're not happy with them, you could move hospices. Or if you have hospice at home, you can get another hospice provider.
Yeah, oftentimes in areas where there are multiple hospice options.
Yeah.
Yeah.
How does the availability of hospice providers impact access to care, particularly in the rural or underserved areas? And what strategies can help address this issue?
Yeah, so I think some change at the federal level in terms of compensation will make an impact on the ability to actually run a hospice in a rural area, because a rural area where geography is extensive and you have to travel a great distance for that home-based care, that those add up to huge costs, right? And also rural areas, we struggle to find providers of all kinds. It's hard to attract a physician to our area. It's hard to attract nurses. And so things that improve the reimbursement in rural areas would actually help here. Now, that said, I would say that rural providers can't just be relying on the fact that they have a hospice, they open up a shop, and they're ready to go. Going back to a conversation, the part of the conversation we had earlier, where The rural provider has to be one that is cognizant of the barriers to hospice in this community. What is the cultural aspect of this community? So the rural provider has to be aware of the service area that they're providing the service in. Are there people, is there a greater extent of death phobia in this area? Is there more of a community which focuses on family kind of coming in and being the providers and protective? Is it an area where, like ours, where there's a significant amount of spiritual there's a number of tribes in our area, and their tribal practices are very different. We have to be aware of that, and we have to be supportive of that. We can't just open up shop and say, oh, we're here for hospice for everybody, but the tribal community practices death and dying in a very different way. We have to be able to support that death and dying practice as that tribal community practices it. So there's those pieces of providing care in a rural community. And I think that also in a rural community, there needs to be more education. There needs to be more of those conversation opportunities at the library, at forums where people gather, going and talking at churches, those kind of areas, and getting people more comfortable, again, to that, what we talked about at the beginning, that death phobia, getting the community as a whole more comfortable and introducing it in forums where people are more comfortable.
What advice would you give to families who are facing barriers to access hospital care? What advice would you give to families who are facing barriers to accessing hospice care?
Right. So I talked about the state organization. They are always there to reach out to. But number one, talk to your primary care providers, talk to your cancer care providers. Tell them your wishes, talk to your family, tell them your wishes so that people are aware that you want to access comfort care and not as much about, all out heroic care to cure, right? I think those conversations will start the process, especially provider conversations, to say, this is what my wishes are. This is how I want my life to play out. That will make a difference. And where you can't get access to care because the hospice is just not available or whatever, use your state organization, advocate from there. There are area agencies on aging. Reach out to them about resources that will allow you to access care. And then get your advanced care planning done. Right? That's a piece of have the conversations you need to have so that you've got everything written down and in order so that you can actually access care without being this huge stress ball on top of your head, right?
Yeah.
Yeah.
So Priya, thank you so much for being here. How can our listeners learn more about VHOCC and do you have a donation page?
Yeah, we do. So our website is volunteerhospice.org. Simple as that. And from there, you can navigate to give to us, to donate, and also to find out about our history and our incredible founder, Rose Crum. And if you want to come join us, we're hiring part-time and per diem nurses right now. So if you want to come join us, we also have jobs posted there.
Wonderful. Folks, understanding the barriers to accessing hospice care and the incredible efforts being made to overcome them is crucial for ensuring everyone gets the compassionate care they deserve at the end of life. Remember, accessibility and provider availability are key to making hospice care equitable for all. I'd like to end today's conversation by reminding everyone that over 95% of volunteer hospice of Clallam County's budget comes from the community. To fully support people, they do not accept money from Medicare or other insurance providers, and their support is 100% free to those who use their services. Please consider donating to them. Any amount helps. The link is in the episode's description. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comforting Closure, wishing you peace and comfort in your journey. Until next time, take care.